Hey everyone, Ryan here from IKN. So in this video, what we want to do is briefly discuss the importance of deconstructing whole body movement tasks into their local isolated parts, their isolated components, okay? And this is really important to us at IKN because when individuals come to see us and when they come to see you with a pain experience or a movement limitation, they'll typically tell you they're aggravating tasks, okay? These aggravating tasks, so we'll just call them AGs here, they're typically whole body tasks, meaning they involve multiple parts moving together, okay? Now what's very difficult about that is when you're looking at whole body tasks with multiple joints that are spreading range of motion, sharing in range of motion, you're looking at multiple muscles that are contracting to produce force and spreading force across the body. If an individual has pain with a certain whole body task, that's why we would see it as an aggravating task, then it's very difficult to only use that whole body task to determine, well, what is the limiting factor there? What is driving that pain experience? What is driving that limitation? Okay, and that's why we have to look at the local parts. Okay, now from a rehab perspective and a movement perspective, we need to really simplify this. Okay, and we need to look at this from a movement perspective. Okay, because if we're looking at aggravating tasks, aggravating movement tasks, that is what movement is. We then need to simplify what movement is. Okay, and that will help us then gather clearer information. Okay, and we're actually going to discuss this within the context of a recent Instagram post. I'll put that on the screen here, where we're looking at an individual go through a forward bend. Okay, now this forward bend involves multiple joints moving together. Again, two of the big motions here involve spinal flexion and hip flexion. So we're asking the question here in this post, what does the pelvis, we're kind of zoning in on the pelvis and saying or asking, what does the pelvis have to do in order to allow this person to reach further towards the ground? Okay. Does it need to rotate backwards to afford the spine the ability to rotate forward? That's what's necessary. You need to get into that posterior pelvic tilt to allow the spine to rotate forward. Because if that pelvis rotates forward very early, it's not really going to allow you to flex the spine. That's more of a hinge then in that scenario. Okay. But hopefully you can see in that video that this individual is demonstrating good enough spinal flexion. That pelvis looks like it's more posteriorly rotated, posteriorly tilted. So in order to allow the individual to get further, at least conceptually, we don't know for sure unless we deconstruct what's available, what's unavailable. It's likely hip flexion here. We need to improve or expand hip flexion range of motion to allow the individual to reach further to the ground. And then we have to deconstruct that and say, well, what is the hip? The hip is a combination, or the hip represents the interaction between the pelvis and the femur. And in order to flex the hip, where the body is moving over top of the leg, the pelvis needs to rotate forward. Okay, so we need to set a goal then of increasing hip flexion range of motion. Okay, but we'll dig into the deeper details here about why that's important, because the reason I'm doing this video now is because we were asked the question, well, why does it matter? Why do you actually want to zone in and look at things that deeply? You know, why do you want to zoom in that much here? And we'll discuss why we do want to zoom in this much, okay? So going back to here, we have the aggravating task, which is typically a whole body task, okay? And then we want to break that down to their local components, okay? Well, what are the local components then? We want to simplify this. And for us, movement represents muscular contraction through a range of motion. If you can't contract the muscle, you can't move. If you can't contract the muscle, shorten the muscle to pull on the tendon, which connects to a bone, pulls that bone and creates motion at a joint, you can't move, okay? You can contract the muscle, but if you don't have space within a joint, you can't move. So that's why we break things down into range of motion and to, you can think of as contraction or force production, let's say FP for short there, okay? We break it down into those two components, okay? So let's look at range of motion for a second here. We'll forget about the contraction piece. So I'm just going to rub this out so we can look at the pelvis and the femur interaction here. So we're going to look at the pelvis and femur here. So pelvis here, femur, lumbar vertebrae, okay? So we have a few different interactions there. We have the interaction between spine, pelvis, and femur. And so let's say, for example, that individual in that video here was experiencing pain. Let's say they were experiencing pain, let's say, the back of the spine, SIJ region, and they were experiencing pain at that range of motion during that toe touch, okay? And then we want to understand, well, okay, what's driving that pain experience? Okay, what can we do to kind of turn that whole body task into language that we can better make sense of, that's more tangible, so that we can actually make it a clear decision on what to do in order to influence that, okay? Well, what we need to do then is we need to deconstruct that whole body task into its components, and we want to try and see, can we link that pain experience with an isolated range of motion? Again, we're just looking at range of motion here. I know force production needs to be linked in with this, okay? So from a range of motion perspective, let's just say we're looking at, again, spinal flexion and hip flexion. So in this whole body task, we can say, okay, well, it looks like that individual is flexing their spine quite well, but it looks like the hip is not really flexing well, okay? So I can get an idea of what's available from a range of motion perspective, but I don't really know what components of that whole body task is linked more with the pain experience, okay? So let's consider this. You might think that, okay, spinal flexion has full range of motion there. They have good spinal flexion. But just because you have good range of motion does not mean it's non-painful, okay? So let's present a case scenario here that I do see quite often clinically. Let's say that when we deconstruct them, we won't talk about the actual assessment that we would do, but let's say we deconstruct that into its individual components. We try and look at spinal flexion without hip flexion, and we go through a classification process within our IKN courses. This is what we do largely in our online courses, and we use this to guide our rehab approach and what we do from a rehab intervention, exercise, movement perspective. So let's say we classify that spinal flexion as being within normal limits, meaning they have a full range of motion, but it is painful, meaning it's linked, it's associated with pain, okay? Now we can go deeper into the location of pain, into the likely source of pain. Are we looking at the disc? Are we looking at a nerve? Are we looking at the facet joints? Is it more of a soft tissue, muscular overload? I do think that's important to a certain degree as well, to help the client understand, what's going on there, even though we cannot be certain. Okay, so within normal limits, non-painful, meaning they have the range of motion, but it's painful. And let's say then we looked at hip flexion, and that was, let's say, L for limited and non-painful. Okay, so even though it looks like hip flexion is a thing that this individual is missing, it's limited, but it's not painful. But the thing that looks like is moving well, the spine, is painful. Okay, what we need to do now is make a decision on what do we need to do in order to potentially influence that pain experience. Okay, and what we need to do then is we need to move into a process of, you'll probably know where I'm going here, we need to generate a hypothesis. Again, we need to think scientifically about this, and this involves, and I know we don't have a lot of information here, but we need to generate a hypothesis as to why we think the individual is experiencing pain. And we don't need to do just one hypothesis. We need to have 2, 3, 4, maybe 5 potential explanations as to what's going on here, because we can't be sure. Pain is complex. but we need to at least have something to work towards, okay? So let's say we step back and say, okay, well, maybe the individual is experiencing pain at the spine during a toe touch, because maybe the individual is expressing most of the motion through the spine. Maybe the spine is being overloaded with the task of doing all the movements, and so it's experiencing all the pressure, all the strain. Secondary to a hip that is not really contributing to that task. Okay, and so I say, well, okay, from a treatment rehab perspective, I think that we may be able to influence that pain at the spine or reduce the linking of that spinal flexion with pain by expanding hip flexion range of motion, which is limited and non-painful. Okay, so what I do then is I'm going to rub this out here. I essentially create a goal. This seems obvious, but again, you'd be surprised at how many people don't go through this process. They just say, I know exactly what's going on there by looking at that task, and here's the best exercise that I know in order to achieve that. Again, for me, that's just dishonest. I'm sorry, it's just dishonest. It doesn't really involve a process. And for me, this is why so many people experience persistent symptoms, because they're told with certainty what someone needs without really going through a process of understanding this. And because there's no process that you go through, then if it doesn't work from that other perspective, meaning you're overly certain as to what they need, if it doesn't work, then what do you do next if you didn't have a process to work through? When we have this process and we map things out, we essentially like to create a movement map. What's available, what's unavailable, what's non-painful, what's painful. We map that out and we generate a hypothesis, an explanation as to what we might need to do about this. Okay, so we create a goal. That goal is important because what we do then is we choose an intervention to allow us to work towards that goal. So the goal might be increase hip flexion, range of motion. Again, really simple goal. Now, what's important here is that hip flexion range of motion was limited. That's why we want to increase it. But it was non-painful. Okay? That means that when we are utilizing interventions to expand that, we don't have to be as cautious. Okay? Whereas if, for example, that was limited and painful, and let's say that I did want to try and expand that. Let's say when I checked hip flexion, there was pain at the lumbar spine, at the SIJ, sacroiliac joint, at around 110 degrees. Okay, well, maybe I could say, well, okay, what needs to lengthen in order for the hip to flex? The glutes need to be able to lengthen. Maybe the glutes aren't tolerating that stretch. Maybe I want to get some length into the glutes and at the same time increase the contractile tolerance through the glutes as they begin to lengthen. And maybe that might help us expand that hip flexion range of motion. But when it's painful, I need to respect the barrier. I need to be a bit more cautious. I need to do a little bit here, do a small bit. I need to probe the system with my intervention and then check back in to see how they feel. Essentially, I need to go through a test, treat, or intervene, and then retest. So I need to establish, of course, a baseline. And then I need to go through this feedback loop of then retesting and checking in with what's actually working for that individual. And ultimately making sure, number one, if we rub this out here, number one, I don't flare the client up, because essentially when we utilize an intervention, we have three potential outcomes, right? So the outcomes are either feels better, feels the same, or feels worse. Okay, now when we're using a retest, we can use the whole body task, that's gone there, the whole body task forward bend, because let's say there was pain with that, but we didn't know what component was linked with pain. And we can use the deconstructed, the more isolated assessment of spinal flexion, which we determined was within normal limits and painful. So we choose an intervention, with the goal of gradually expanding hip flexion range of motion, we check back in at the beginning when we are choosing the intervention. And this is where people always have the question, well, what's the best exercise for that? Again, you don't know what the best exercise for that unless you go through this process. You have to go through the process of identifying what's limited, what's within normal limits, what's painful, what's non-painful, to get to that decision, to know, okay, what might be needed here. Okay, so when people ask us, well, what's the best exercise for that range of motion or this issue? You don't know until you move through a process. People are missing the process here, okay? So you choose an intervention. And let's say, for example, I'm choosing an intervention to, again, have an influence over pain, okay? Of course, I'm looking for something to feel better in that scenario, okay? But when I'm working with a system that's in pain, I don't want to just throw lots of reps in the system. I want to begin with maybe 1 to 2 reps. Or if I'm using more of a kind of a static contraction, an isometric contraction, I might do it for maybe 10 seconds. I'm going to keep the the contraction intensity low, and then I'm going to retest. Okay. Now, when you retest, in the first time, so let's say this is kind of round 1 of your retest approach. Round number 1. You don't know how the client's going to respond to that intervention you're using. You just don't know, because you don't know until you do something and see how the client responds. You're going to be cautious. You're going to retest. You're basically going to make sure they're not worse. If they're the same, okay, that's fine. But I want to start increasing things here. I probably didn't give enough stimulus to really recalibrate the nervous system, to get the nervous system's attention. I didn't give the system enough input to really influence a change in the output. So I start to increase the reps maybe. I start to increase the seconds I'm holding for, the duration of the task. And I'm chasing better, okay, when pain relief is the focus. But here's the key thing. Again, I think I might have said that I'm kind of riffing here because I'm just talking about this relative to the question that we were asked from the Instagram post. Rub this out here again. I need to get a bigger whiteboard. So, where was I going here? In this case, remember, we had hip flexion. That was limited, non-painful. Lumbar flexion. Within normal limits and painful. So you can kind of step back here and say, well, in order to potentially influence that pain that's linked with the lumbar flexion, do I need to get the lumbar spine to flex more? It's within normal limits, so likely not. Might I need to change the contractile tolerance? Maybe I need to get some load into the lumbar extensors. Maybe I need to get some load into the lumbar flexors. That's a potential explanation. You test it. You run the experiment. You test it. Okay, you have to think like a scientist here. You kind of have to apply the scientific method here to rehab. Okay, but when I am chasing hip flexion improvements, I know that I have something that's limited, non-painful. So if I'm trying to influence the pain linked with this, yes, I'm trying to chase something, a better outcome, but I'm also trying to say, okay, does hip flexion actually improve? So after that intervention, does hip flexion actually improve? Because if it doesn't, and the lumbar flexion is still associated with pain, well, that makes sense then, okay? But let's say hip flexion increases very rapidly. If something like hip flexion, a range of motion increases, so let's say we get an increase in hip flexion range of motion within the session. So within the session, what do you think was driving that hip flexion range of motion limitation? Probably wasn't a structural thing. It was more likely a neurological limitation, neurological protection, increased muscle guarding, a stiffening strategy, for example. Okay, why? We don't have enough information here to really, delve into that, but that's likely what happened there. So let's say we recheck hip flexion. That's now become better range of motion wise, because it was non-painful, we're not looking for a pain improvement, but we come back and check lumbar flexion range of motion, and all of a sudden that feels a little bit better. Okay, well then we've tested our hypothesis and we can be more confident in saying, well, maybe that's what's driving the limitation. We can't be certain because there's lots of things, there's lots of potential mechanisms that could be underpinning the reduction in pain. Lots of, mechanical, physical and non-physical explanations. Okay, this person might not have moved in a long time, and just getting some stress, some physical stimulation into the system may have kind of increased the confidence of their body. Maybe just getting some load into the hip that was non-painful just allow them to be a bit more confident and disconnect that movement equals pain type of feedback loop. Okay, so they might feel a bit safer with movement. It reduces that neurological protection. Okay, so in that scenario, we are chasing two things: increased hip flexion range of motion and the reduction in pain. But what if hip flexion did not improve? Okay, if within session range of motion, hip flexion did not improve, it's looking like, okay, this individual, it's going to take a few sessions here to really increase that range of motion here. Maybe when we delve into the injury history there, there's been some surgery at that hip in the past, maybe some poor rehab post-surgery, and that's reflected in a hip that is very, very stiff, that needs more stimulus, more input to influence the range of motion. Then what we're doing there is we are stepping back and saying, well, okay, maybe I'm not really chasing better. I'm not chasing a better outcome here, because I'm having a conversation then with the client and saying, okay, well, that hip is very stiff, and I'm linking that back with their subjective, their story, the history of surgery at the hip, potentially other things going on, and saying, well, it might take some time for us to improve that hip flexion range of motion, which means it may take some time for us to experience a reduction in pain connected with lumbar flexion. Okay, so that's why it's helpful for us to deconstruct things, because we can have those conversations. We can gather more tangible information from the system, from a very complex movement system. And many people will say, well, the system doesn't operate by parts. Well, it actually does. Movement emerges as a result of the interaction across parts. And here's the thing, when you have a problem in a part, that's when you really see it. If you have a pain at your low back, a part of the system, what's that going to do to your whole body movement? That's going to make your whole body move differently. So a part of the system is influencing the whole body. So what do we need to do then to influence the whole body? We need to influence the parts. We need to increase the tolerance to load there. Again, which really is, again, increasing what the system can handle. That's linked to pain as well, where we have a reduction in tolerance. Okay, so hopefully you can see the thinking process behind that and why it's important to deconstruct things. Again, I know I kind of went off on a few tangents there, which I typically do, but I just wanted to kind of delve into that for you, connected to that Instagram post, that video of the forward bend, and really break down our thinking process here. Okay, you gather, which really comes back. We'll really simplify it here for you, just to finish off. So generally what we're doing here is we have to gather information. Okay, the process here involves gathering information. We do this from the person's story, their subjective information, the objective movement exam. Okay, and then what we need to do, as a result of the information that we gather, like I said, we need to generate a hypothesis. Why are they experiencing pain with that aggravating task? And then what we need to do is intervene in some way. But this is where you can think of the scientific method being applied here to the rehab process, because then you have to run experiments, mini experiments. You have to run your experiments, and then you assess the response. And then you go from there. How are they responding? Same, better, worse? Are you okay with it being the same? If you're trying to expand something that is really limited, like the hip, for example, if there was a history of surgeries. If it's better, brilliant. Let's plow on. Let's continue with that, okay? But we miss out on this. We think that this is a sign of weakness. We think that if we don't know for sure that we are a weaker therapist, that's problematic. That's not the scientific process. That's not honest, in my opinion. So we need to get comfortable with this idea of running mini experiments, but the outcome that we gather from that, we need to know what to do with that outcome. And if we don't have a process to follow, to gather information, to generate a hypothesis, to run mini experiments, which is essentially, again, your movement, your exercises, other modalities, why are you doing these things? You need to understand why you're doing these things. Because if you don't understand why you're doing what you're doing when you're running experiments, if the outcome of that experiment doesn't connect with what you hoped it did, then you're going to look a bit foolish, especially if you are very certain with, I know exactly why you're in pain. I saw this great exercise on Instagram. You need to try this. Oh, it didn't work. Well, I don't know what to do. And honestly, this is really important. This can really drive a lot of issues, particularly when people are experiencing persistent pain. Because if you're very random with your inputs to the system, very random with things, and individuals are believing in you as a therapist, they think you're the person that can help them, and you're just throwing random inputs to the body, and it doesn't improve, then what are they going to feel like? They're going to think, I'm a really complicated case. I must have something, quite badly wrong with me here. Nobody's able to help me. But in reality, nobody's following a process. This is what I see most commonly clinically. And in that process of you throwing random inputs at the system, the individual is becoming deconditioned, maybe becoming more fearful and avoidant of movement. And then that's creating more messiness when it comes to the rehab process then as well. So having this process, and again, this is just a really broad snapshot of that process, is incredibly important. It allows you to really step back and troubleshoot things, problem solve, and really think your way through things. And that's what we do on our IKN courses. So if this resonated with you, if it's interesting to you, if you want to integrate this kind of thinking into your approach, along with lots of unique assessment methods, exercise strategies, loading strategies, with a very unique framework to guide that as well, to plug those exercises into a progression and regression pathway. If you're interested in that, check out our online courses, okay? We'd love to have you there. And if you made it all the way through the video, thanks so much. I know I went off on a few tangents here, but hopefully you enjoyed this. Let me know in the comments if you did, and I will be sure to do many more.